So what I'll try to cover is talking just a little bit about those drugs that you were hearing about that use T cells as a way of sort of demonstrating how important T cells are in melanoma and melanoma treatment, and then talk about what's called adoptive immunotherapy. And that basically means you've created an immune response outside of the tumor, and then you're giving it back to the patient essentially fully formed. So tumor-infiltrating lymphocytes, or TIL, are important in melanoma, and we've known this for a long time. We know that natural recognition, the body naturally recognizes melanomas as abnormal. And so in this image, you can see the top half of that picture are melanoma cells, big ugly melanoma cells, and the bottom half of the picture is just filled with these tiny little lymphocytes. And the lymphocytes are the immune cells. They're there to recognize something when there's something wrong with it. And you can see even a few of those cells have percolated up into the tumor. And then they're not there by accident. And we've known for a long time in melanoma that if you have those cells, your long-term outlook is much better than if you don't. We just haven't really known what was going on in there as well as we do now. And we know that if you have progressive metastatic melanoma, that natural recognition of your tumor by your immune system is not good enough. And so can we harness that, though, in a way that enables us to treat people who need that treatment? As you've heard and will continue to hear, there's been really just a world change in melanoma and melanoma treatment over the last few years. And just to sort of illustrate that, this is a timeline of drugs approved for melanoma over its history, basically. And so back in the 70s, there was chemotherapy that was approved, and it took another 10 years and more before anything else was approved. And there you have interferon and interleukin-2 that you heard about that were approved, and then there was a big gap again. And now, it's just been really remarkable, and you heard about 2 new approvals this week with new drugs, not for melanoma specifically, but pretty amazing. And you can just contrast the left side from the right, how different things are now to what they were not long ago. And T cells have been a big part of this. So many of these drugs use T cells as the way that they actually get at the tumor. The drugs themselves don't do anything to the tumor. They affect your immune system. And so the ones that are circled here are certainly dependent on T cells to do anything. So I think you'll agree they're important. The other important thing I think about T cell and immune-based therapies in general is the durability of the response. And so this is that old-timey drug, IL-2, that was one of the first to be approved. And you have there on the right one of those survival curves. And the remarkable thing about the survival curve is how flat it is. And so that means essentially from about the 2-year point, if you've had a complete response to interleukin-2, you'll never recur. And this now is 10 years worth of follow-up. So one of the older drugs, been around a long time. We know how these people do over a long period of time. The downside of it is the table on the left. And that's why that drug was not universally used, and that very few people actually respond to it, and it's pretty toxic. But really tantalizing that you can achieve these very long-term positive effects in patients. This is a similar, relatively long-term follow-up curve for ipilimumab, and again, on the right-hand side of that curve, you have that very, very flat curve. So if you've made it past 3 years with a good response to ipilimumab, chances of you recurring after that point are very, very low. The trouble with that curve, as you can easily see, is that it's a long drop-off before you get to that plateau. And so can we do better? This is pembrolizumab, one of the PD-1 inhibitors that you've just heard about. And again, early data, and the question here is, will that curve at the end be as flat as the other curves that you've seen? And I don't know that we know that yet, but certainly the response rates and toxicity are so encouraging, and certainly this is a great advance as well. So how does it all work? You've seen some cartoons, so I'll show you some additional cartoons, my cartoons, about how this might all work together. So if you have melanoma, melanoma cells, they may die on their own. They may release antigens or proteins that they've created that are abnormal, and then the body can pick up on those. And there are cells that take these things in and process them and show them to the immune system. Those are dendritic cells. And once they've been activated, they mature and they really get going and revving up a new immune response. And then they talk to those lymphocytes and tell the lymphocytes what to do. Tell them that there's something wrong and to go off and find it and kill it. And then they go off and they find the melanoma and hopefully kill the melanoma. And this is a cycle that can then build on itself over time. And you can help this cycle along with helper cells. You can inhibit it with regulatory cells that block the ability of those lymphocytes to do what they do. But eventually, here's just a picture of what that might look like. The big cell is a tumor cell, and the smaller cells are the lymphocytes that are getting in there to recognize it and kill it. And so the advanced thinkers, like the ones you've heard from in the panel, have explained it to the simplistic people like me as driving a car. It works like driving a car. And so you have a steering wheel and an ignition and a brake and a gas pedal. And so the ignition might be when this antigen-presenting cell gets turned on and the car gets revved up. The steering wheel might be this receptor on the T cells. And so the T cells have this thing on their surface that basically tells them what to go after. So it sort of steers them in the right direction. You have brakes and gas pedals. And so the brake might be something like the PD-1 or the CTLA that you've heard about. The gas pedal might be a helper cell. It might be a cytokine like interleukin-2 that pushes it and accelerates the car. So how do some of these brakes work? So the ipilimumab, in my mind, works sort of more like a handbrake. Here you have an interaction of a lymphocyte with an antigen-presenting cell. That's where the antigen-presenting cell gets turned on. And so there's an interaction of stimulatory molecules on the surface of the T cell with that antigen-presenting cell, and that really gets it revved up, and then it goes off to kill the cells that it's supposed to kill. Eventually, once it's done that for a little while, it comes back and meets up with these antigen-presenting cells again. And now, instead of having that stimulating marker on its surface, it has a different one called CTLA-4 on its surface. And that, when that interaction takes place, it turns that cell off. And it's a way for the body to just shut down an immune response once it's done its job. But it essentially works like a handbrake. So once you've done your errands and you get back to the garage, it goes on and that cell gets turned off. There's also a foot pedal brake, and that's the PD-1. And so that's as these T cells are driving around through the body, they can come upon things. And on the surface there's the same interaction of the T cell receptor with whatever the target is on that cell. But at the same time, there can be an interaction of PD-1 on the lymphocyte with PD-L1 on the tumor cells. And that's that defense mechanism that the tumor cells have. And when that happens, it turns that cell off as well. And so the drugs that you've heard about now, the Yervoy and the PD-1 and PD-L1 drugs, operate at those breaking points and release those brakes to allow the cells to continue to do their job and kill the tumor cells. And there are lots of ways of manipulating that then. And those drugs are examples, but you can accelerate the death of the cancer cells with radiation or chemotherapy or other local treatments. You can accelerate the ignition switch with things like BCG or Coley's toxins or other stimulants to the maturation process. You can push things along with interleukin-2 for the lymphocytes. There's CD40 ligand, anti-CTLA-4, anti-PD-1, anti-CD25, tyrosine kinase inhibitors. So there are lots of, and that's just a tiny fragment of the potential ways of getting at this system. So it's easy for them to tell me that it's like driving a car, but it's actually probably more like flying a space shuttle. And so for the simplistic people that are dealing with this, we like things that are, you light them off, send them off, and you know that they're going to do what they're intended to do. And so that's the T cell, and that's where the adoptive immunotherapy comes into play. And so in that, there is sort of a standard working model of that, and there are definitely challenges that are involved in using that model as a treatment. And there have been modifications now that are being advanced as ways of trying to improve our ability to use these cells with transgenic lymphocytes and what are called chimeric antigen receptor lymphocytes, using the mutanome, which I'll talk about and tell you what that is. And then the last little bit I'll throw in at the end is about what are called bispecifics. So we'll go through those things. The standard working model for this, which was developed by Dr. Rosenberg at the NCI, involves sort of the knowledge that we've seen that lymphocytes can infiltrate into tumors in the body. We can surgically remove those tumors. And then outside of the body, you can look in there, you can see those same lymphocytes that are in that tumor, trying to kill it but not actually killing it. You could take those tumors and put them in the lab into conditions that favor the growth of the lymphocytes over the tumor cells, and then those lymphocytes proliferate in the little wells in the lab and eventually kill the tumor that's in those wells. You can take those lymphocytes and test them against the patient's own tumor or other melanoma targets. And if they react, if they're specific, if they can kill those melanoma cells in the well, you can take those specific ones and put them into special culture conditions that cause rapid expansion, rapid growth and proliferation of those lymphocytes into many billions of cells, and then give those cells back. And so this was initially pioneered. They got the cells together, they gave them back into the patient, and they went off to do their thing. But when they looked back for those cells, even just a few days later, they were mostly gone. And so the body kind of knows in some way how many lymphocytes it's supposed to have. And if you overload it with lots of other lymphocytes, they get deleted. And so they did not see terrific levels of response to this initially until something called lymphodepletion was enacted. And essentially what this does is it creates space, you can think of it, for the lymphocytes that you're about to infuse. And it's giving chemotherapy, a brief period of chemotherapy, to get rid of the lymphocytes that are in the body before you give back the cells that you've grown in the lab. And this is just an example of one of the studies where that was done, where they, on this timeline, they gave the cells here and then the interleukin-2 and found that the cells were mostly gone, but then they used this chemotherapy to get rid of the lymphocytes that were in the body and re-infused after that. And you can see that indeed you knocked off the lymphocytes in the body with the chemotherapy, and you had spikes in these what are called homeostatic cytokines. They're essentially chemicals the body makes to support the growth of these and existence of these cells. And so you had those. The cells then persisted, and you then, with this lymphodepletion, began to see more commonly responses like this, where big tumors will disappear. This is a CT scan of a liver. All the black dots are melanoma, and they disappear, and many of these responses then persist for very long periods of time. And so that was one of the big keys to getting this to work, and you begin to see long-term survival for patients even who had failed prior therapies treated with these cells. So why doesn't everyone do it? Well, because it's not easy to do. So there are technical challenges that are daunting in terms of being able to just give the therapy. It's difficult because there, as you'll see, there's a timeline that's involved in getting from the resection to the actual treatment. You can't always demonstrate or get cells that are reactive in the lab, so you may not have successfully grown cells that you can give back. And it's now given with high-dose IL-2, so that's toxic and hard for some patients to take. In terms of technical challenges, the places where this has been successfully done so far include the NCI. Here's Google Earth of the NCI. It's a small city outside of Washington. This is MD Anderson in Houston, again, a fairly enormous institution. And even here at the NCI, which is the sort of the originator of this and a mecca, you may have seen in the New York Times that their lab was recently shut down for technical reasons in terms of the difficulty in maintaining a lab that is up to snuff in terms of producing these cells. This is St. John's Hospital in Santa Monica. That's the John Wayne across the street. And if we show that to scale, so the question is, can it be done at places that are not those city-sized institutions? And it turns out it can be done there. So this is our little cell production facility, and Hitoya Takura was instrumental in getting the place set up and running. Yu-Chin Kwan is our main technician who does a lot of the cell growth. And so we've established a lab that has been certified by the FDA to do this process. We have a protocol that's open and accruing patients, and there's Yu-Chin with the first cell product of 38 billion melanoma-specific lymphocytes in the bag there that then this gentleman gave the high-dose IL-2 that followed the infusion of those cells. So it can be done. You can overcome those technical challenges, but there are other challenges as well. So one is the timeline of the treatment. And so there you'll take a tumor out, and then there's a period of 2 weeks, 4 weeks, 6 weeks that are ongoing as the cells begin to grow and begin to try and overcome the resistance of the tumor in the lab. And then there's a reliable 2 weeks when you're doing this rapid expansion protocol before the cells can be infused. So it's a couple of months. It may be longer than that in between when the resection is done, when the treatment can be given. And that's a very long period of time for patients with metastatic melanoma. So that's certainly a challenge. You also can not always demonstrate reactivity of the cells that you've grown against the tumor. And so how might you overcome both of those issues, the timeline and the reactivity problem? And one way is by using genetically modified T cells. And so there are a few ways that's done, but overall, you take T cells out of the peripheral blood rather than taking them out of the tumor. And those ones that are in the peripheral blood, they're not melanoma specific. So how do you make them melanoma specific? You could do what's called transfection or genetically modify them. You can insert a gene into those cells that either causes them to make a new T cell receptor, the thing that targets the cell to its victim. So it's just like a regular T cell, but it has a different targeting now. Or you can make what's called a chimeric antigen receptor T cell, and there you insert a gene that's not for a T cell receptor. It's actually more like an antibody, and I'll sort of give you why that might be an important distinction. So it's like an antibody on the outside and like a T cell receptor on the inside. And so those two different types of cells can work in different situations potentially. So the T cell receptor ones work like regular T cells, and they have to recognize their target in something called MHC. So the cells normally put little pieces of their internal proteins on the outside for the immune system to recognize. So what that means is that it can recognize mutations that are only manifested on the inside of the cell, not on the surface of the cell. The chimeric antigen, the antibody-like receptors, are ones that can recognize proteins that are on the surface of the cell. They have to be expressed on the surface, so if it's an internal mutation, you'll never know about it, and they won't be able to see it. But if it's on the surface, it can recognize it, even if the cell has lost some of the normal mechanisms that present in one of the MHC molecules. So there are different approaches, and they have advantages and disadvantages to each. The transgenic T cell receptor has been looked at in melanoma now, and by Tony Rebus at UCLA, and they were able to generate these melanoma-specific transgenic T cells and give them to patients, and they saw sort of hints of responsiveness, so a little bit of shrinkage or a little bit of lessening of the brightness on the PET scan, but they actually didn't get great responses, and they didn't have anybody that had a lasting response. And it may be that with such a focused attack that the tumor cells are able to just change, just modify themselves so that they can escape that recognition. So the chimeric antigen receptor T cells is another approach that's not really being used in melanoma so much anymore, or it's not very far there, but it's being used in other cancers, particularly the blood type cancers. And in that instance, you can insert a different kind of gene, and these are just the responses that have been reported with that. So this is a bone marrow biopsy from a patient with a blood cancer, and the bone marrow is abnormal at the beginning. They infuse these cells that are specific for a marker on the surface of the blood cancer. They then proliferate, and that's this very dark thing in the middle where the cells are really getting in there and killing all of the cancer cells, and then it normalizes to normal bone marrow afterward. And when you look at what's called flow cytometry, that is looking in the blood for these specific abnormal cancer cells, if I can get my pointer again, what you can see on the upper left, that blotch of color in the corner are all the cancer cells. And if you look at the one just below that, in the middle on the bottom, all those cancer cells have gone away. And these can be heavily pretreated patients, but the cells get in there, they grow, they kill those cells, and then they persist and keep those cells away, potentially indefinitely. And so with the technology that's available now, you can do much more than you used to, and maybe that will help us in melanoma as well. And so this can be taken to yet another level, and that is using what's called the mutanome, or using all of the mutated proteins that might be in a given cancer cell. So in addition to the advances in immunology, there have been advances in the genetics of tumors, so not only identifying the BRAF and the NRAS that you heard about, but potentially all of the mutations that might be in a tumor cell. And you saw from Dr. Sullivan's slide of the number of mutations in different tumors that melanoma has a whole lot of mutations that are there. And so an approach that they've also taken at the National Cancer Institute is to take a tumor out. They'll then grow lymphocytes that were in the tumor in the same way that had been done for the TIL that you heard about. But they'll also do whole exome sequencing. So they put the tumor and they sequence all of the expressed genes in that tumor and identify all of the ones that have mutations. And then they search for lymphocytes that specifically recognize those mutant proteins. And so in this patient who had a resistant cholangiocarcinoma, they did this, and they found a specific mutation in that gene. And they, in their TIL culture, identified that about 25% of the cells that were in that culture were specific for that mutant protein. They gave those cells back to that patient, and she had stabilization of her disease. And then they grew more of those cells and actually had 95% of the cells in the next culture that were specific for that mutation, and gave those back and had a response in that patient who would have failed probably everything else. And so this is a massive effort. You can imagine that it's probably not generalizable to everyone, but it demonstrates sort of the capabilities that exist now that are well beyond what we had not that long ago. It doesn't work in everyone, and there are things that happen in the tumor that can prevent even large numbers of these lymphocytes from doing their job. And so this is where these new drugs that you've heard about come into play, potentially as a combination with the cells to get rid of some of those things that keep it from working in other people. It's also not entirely safe. One of the things that you saw in most immunotherapy trials over the years, vaccine trials and those sorts of things, was that it was well tolerated. It also didn't really work. And now, as you've seen, these new drugs have side effects that can be dangerous, but they actually do work. So the CAR T cells are no exception to that. And once you've released these cells into the body, they're alive. And they can grow and proliferate and secrete things, and that's what you want them to do. But it can also be dangerous. And this was just a report of a patient who had received these CAR T cells targeted at the ERB2, HER2 gene, young patient with metastatic colon cancer, got 100 billion of these cells infused, and 15 minutes from the time of infusion was in distress, was transferred to the intensive care unit, and died 5 days later, essentially from the storm that was released by these cells that were infused. So not entirely safe, but there are modifications that are now being made to these CAR T cells that can help to turn them off when they get overactivated. And these are a few strategies that are being used, additional genes that can be put into those cells that make them then sensitive or vulnerable to other interventions you can take if they seem to be getting out of hand. So early days for these types of cells, but very intriguing results so far. The last bit that I'll talk about, and I wanted to talk about it because I know Dr. Hamid is involved in some of these trials, are what are called bispecifics. So this is a way of using T cells without having to make T cells. So one type of these are called BiTEs, or bispecific T cell engagers, and they're essentially like little fragments of antibodies directed at two separate targets. And so one end of the one end of this little engager is specific for a T cell marker, and the other end of the protein is directed against a cancer-specific target. And what that does is bring T cells and cancer cells together. And so there's one being investigated in melanoma, and there's one that's actually approved now in some of the blood cancers. And so what this does is if you have a tumor cell there on the left, these little molecules will be able to attach to it specifically based on that antibody-like end on the one side, and then the T cell will be brought in, not to the specific part of its T cell receptor. It's not a T cell that's directed against that target, but now that that little bit of glue is in there in between the two cells, it holds them together, and just holding them in physical proximity together is enough to get that T cell to kill the thing that you want it to kill. And so this is just a picture, a microscopic picture of a big cell, the big cell, which is a cancer cell with a lymphocyte against it, and that red strip is where that cell has engaged and is in the process of killing that cell. And then that lymphocyte will go off and kill the next similar cell. And so that's something that's now being explored in melanoma as well. So there's a huge amount going on, and there's, as you've seen, a huge amount of progress that has been made. And I was thinking, sitting here with the other speakers, how much this group of individuals has contributed to the advances that you've seen. But then really reflecting on it, there are more people in the audience who have contributed to this than any of the speakers. It's through the patients that have been involved in these clinical trials, have really taken that gamble, that initiative to do more and to participate in these trials that have made all of these advances possible. So it's really a credit to you. And so there are lots of ways that we're going to continue to work to make this better. We recognize that we haven't done a good enough job yet, and there's a lot of room for improvement. And so we'll work at this for you and try and continue to make things better. And the T cell will continue to be a central part of all of this, I think. In the future, we'll be better at identifying targets for those cells. We'll be able to potentially identify these tumor-specific cells from the peripheral blood, which may make this process easier. And really combinations with these other drugs that you've heard about are where I think the most benefit is going to come in the future, potentially not only making it work better, but hopefully making it more tolerable as well. And I just want to thank my friend, Dr. Hamid, again, for the chance to be here. I've been at a few of these things, and it's a great, great event. And you can see he cleans up pretty well at some of these other events. And this is, I think, the only existing image of him not in a suit. So thanks very much. I appreciate being here.
I'd like to